with um our revision for the SCA, let's look at IBD, inflammatory bowel disease guidance. So referral guidance. So when do you refer for suspected IBD? The bloody diarrhea for more than 1 week, particularly if accompanied by tenesmus. So there's having patients with tenesmus, fecal urgency, nocturnal episodes, incontinence, and negative stool cultures. If there is diarrhea or abdominal pain plus one of the following: weight loss, extraintestinal manifestation. So if you're having weight loss, you want to make sure there's no bowel cancer, for instance. You want to probably be referring for a colonoscopy. If you're having extraintestinal manifestations, then at that stage you want to be referring to gastro. So the patient might actually need some further treatment, some immunotherapy, for instance. The family history of IBD, abdominal investigations, iron deficiency, B12 deficiency, anemia, etc. Now consider admission directly to gastroenterology for patients who 6 or more blood emotions per day, plus one of the following. So there's pulse greater than 90, fever, temperature greater than 7.8, HB less than 10.5 gram per day, the CRP is greater than 45. So which means if the patient is having features of sepsis, essentially, you want to refer for admission. Now, how do you manage Crohn's disease in primary care? Patients have Crohn's disease, you have 2 phases. You want to induce remission, you want to maintain remission, essentially. Now, for induction of remission, if it's an ileocecal disease, Crohn's disease, it's a mild disease, no treatment, you can use budesonide 9 milligrams once a day. If it's moderate Crohn's flare, then budesonide 9 milligrams once a day, or reducing dose of prednisolone. It's colonic. It's difficult clinically, to be honest. It's difficult to tell you it's ileocecal, colonic, or papagia. Well, obviously, the patient has had, a colonoscopy before. And then, based on the colonoscopy results, it showed ileocecal Crohn's, colonic Crohn's, RGI versus upper GI endoscopy. So, depending on the symptoms and previous endoscopy findings, it's colonic, it's mild, so no treatment, or it's only very reducing, course of prednisolone. You can use sulfasalazine or gram. So second line option for mild disease associated with arthropathy. You can use 4 grams of sulfasalazine. There's upper GI involvement, total pump inhibitor, with prednisolone cause if necessary, reducing dose of prednisolone. Now, maintenance of remission. Don't be encouraging patients to stop smoking. Smoking cessation is an important factor in maintaining remission of Crohn's. There's no role for mesalazine in medically induced remission. Patients who relapse early or who have steroid-dependent or refractory disease will be treated with either ibuprofen or captopril. Obviously, you have to refer that patient to the gastroenterologist, who will then be the ones to be starting these therapies, disease-modifying therapies. Now, managing ulcerative colitis in primary care, same thing, same principle. We want to induce remission and we want to maintain remission. Now, how do you induce remission in ulcerative colitis? For mild to moderate disease, so that's for proctitis, which is like a very distal ulcerative colitis, initial treatment will be mesalazine suppository. So if you use mesalazine suppository, if you use mesalazine formula, mesalazine suppositories, so 500 milligrams to 1 gram a day. The symptom persists after 3 to 4 weeks. You could add oral mesalazine, the dose of 2 to 4 grams per day, pentasa, or 2.4 to 4 experimental. So you can use pentasa or octasa. Patient is not improving on combination amino acid, which means you're using the rectal mesalazine and the oral mesalazine. Patient is still not improving. They refer to individual patient management plan or contact the consultant gastroenterologist. This mild to moderate disease, this left-sided extensive starts treatment with mesalazine foam, still rectal, or retention enema, plus oral mesalazine. So I think that if it's a proctitis, then of course suppository. If it's higher up than proctitis, you want a foam retention enema, a foam that goes deeper into it. A moderately active disease, oral mesalazine 4 gram per day, pentasol 4.8 gram per day, optasol increases clinical response, not remission, and reduces time to bleeding cessation. The reducing cause of oral prednisolone is appropriate if symptoms fail to settle in less than 4 weeks, or they deteriorate on treatment. Severe disease, bone gastroenterology, registrar consultants, when treating an acute flare of rectal mesalazine, local specialist notes. It can take up to 14 days before a response treatment is seen. One symptom-free patient should continue treatment for a minimum of 14 days, then alternate days for 7 to 14 weeks, then stop. And patients may continue the treatment several times a week for alternate days after maintenance to prevent breakthrough bleeding. Now, when you induce remission in ulcerative colitis, how do you then go on to maintain a remission? So approximately 70% of patients ulcerative colitis will relapse at 12 months. So oral mesalazine 2 gram per day, pentasol 2.4 gram, which is half of the dose that is used to induce remission. Is the first line treatment for maintaining remission, European Crohn's and colitis combination echo. Guidelines recommend that patients maintain a dose of oral mesalazine at least 2 grams per day. The echo European Crohn's and colitis recommending that patients with ulcerative colitis should remain on these pentasol oral mesalazine at least 2 grams per day. Patients on higher doses could try out stepping down high dose oral mesalazine after being stable for 6 to 8 weeks. The escalation of doses should be considered on an individual basis. So certain patients may need to remain on higher doses to maintain remission. 1 gram suppository on alternate day, an acceptable alternative for proctitis. The recommended mesalazine is continued long term, since this may reduce the risk of colon cancer. So that's interesting. I never knew that mesalazine reduces the risk of colon cancer. So patients who are experiencing symptoms on their current regimen should be reviewed and treated and treatment optimized. So that's good. Let's look at chronic fatigue syndrome. So signs and symptoms. So following the release of the updated NICE guideline, the criteria for diagnosis and considering a referral to specialists, ME or chronic fatigue services now more stringent. Patients should only be referred if they are experiencing all 4 symptoms outlined below for 3 months or more. The symptoms as follows: if they're experiencing debilitating fatigue that is worsened by activity, it's not caused by excessive cognition, it's not caused by excessive cognitive, physical, emotional, or social exertion, and it's not significantly relieved by rest. They're having post-exertional malaise after activity in which the worsening of symptoms is often delayed in onset by hours or days. It is proportionate to the activity, has a prolonged recovery time that may last hours, days, weeks, or more. Unrefreshing sleep disturbance, or both, which may include feeling exhausted, feeling flu-like or stiff or waking, broken or shallow sleep, another sleep pattern or hypersomnia. The patient is having cognitive difficulties, sometimes described as brain fog, which may include problems finding words or numbers, difficulty in speaking, slowed responsiveness, short-term memory problems, and difficulty concentrating or multitasking. So chronic fatigue syndrome should be suspected if a patient has had all of the 4 key symptoms persisting for a minimum of 6 weeks. whereby diagnosis of chronic fatigue only made when a patient has had all four key symptoms persisting for a minimum of 3 months or more. And symptoms should be definite onset, that is not lifelong but chronic, not the result of ongoing exertion or overactivity, not the result of excessive working hours, not substantially delayed by rest. So you can see this, the person is working so hard, for instance, and is burnt out at work. You're not going to make a diagnosis of chronic fatigue syndrome. That's why they're emphasizing some of it, because they know that there's increasing pressure in the workforce. People are getting more and more burnt out. And that's why people are having fatigue or exhaustion. And a lot of people would actually be thinking they have chronic fatigue syndrome. So you have to have that debilitating fatigue that is actually worsened by activity, unrefreshing sleep when you try to rest, and exertion fatigue that is actually far more, disproportionate to the activity that you think would actually make any person feel tired. Oh. So chronic fatigue syndrome exclusion criteria. The following conditions would exclude the diagnosis of chronic fatigue syndrome and should be screened for prior to referral. If there's established medical disorder known to cause chronic fatigue, this is especially important in the elderly. Even cardiac, respiratory, and neurological causes of fatigue can be frequently missed. If patient has psychosis such as schizophrenia, bipolar disorder, patients abusing alcohol or drugs, if the patient has eating disorders like anorexia, bulimia, severe obesity, BMI greater than 40, BMI less than 18, adults with behavior or conditions which prevent engagement with service, you need to exclude fibromyalgia and fibromyalgia the primary diagnosis, or where pain dominates fatigue. See if the patient has severe depressive illness with psychotic or melancholic features, but not anxiety states or mild or moderate depression. Yes, somatoform disorder, somatization, and then possible dementia. Essentially, the person has, you have to rule out a physical cause for the patient's fatigue before you can then investigate, or for before you can start considering a diagnosis of chronic fatigue syndrome, which obviously would have to be a diagnosis of exclusion. Dementia care pathway. So let's have a quick look at these 6 seats. The questions that you may want to ask when you're assessing for memory loss. So you want to find out what year it is, what month it is, what time it is. Correct to the nearest 1 hour. Count backwards from 20 to 1, say the months in reverse order, and then repeat the address that was given initially. We name an address, John Smith, 42 High Street, Bedford. It can be different. I just have the one you commonly use. The other 6 and then the GP, assessment of cognition, GP cog. For the GP cog, there are 2 aspects of the GP cog. Let's go through it together. The GP cog patient examination. Let's specify each question should only be asked once. Name and address for subsequent recall. I'm going to give you a name and address. Ask. After I've said it, I want you to repeat it. Remember this name and address, because I'm going to ask you to tell me it again in a few minutes. To John Brown, just give them a name and address. You can say, John Kent or John Willis or whatever. Peter Wright, can let me use your own home address. It's easier to remember. So what is the date? Clock drawing. So that's you're checking visual special function in a paper and a printer. Obviously, in SCA, we wouldn't be doing that. In real life, well, if you have time, lots of You can't be doing this in a 10 minutes appointment, you know what I mean? This is something that will be done at the memory clinic. Because in a 10 minutes appointment, you will have time to tell the patient to draw a clock. And if you book it as a double appointment, 20 minutes. Please mark in all the numbers to indicate the hours of the clock. So like 1 o'clock, 2, 3, 4 hours. Or a correct response, blah, blah. Please mark in. And then GP cog informant interview. So then GP cog, there is one that the patient does. There's another one that the informant does, visibility, for instance. Ask the informant compared to a few years ago. Does the patient have more trouble remembering things that have happened recently? Does he or she have more trouble recalling conversations a few days later? When speaking, does the patient have difficulty finding the right words or tend to use the wrong words more often? The patient less able to manage money and financial affairs, like paying bills, budgeting. Is the patient less able to manage his or her medications independently? Does the patient need more assistance with transport, such as private or public? So the GP cog, is the one you do. So in the SCA, what's essentially you're doing is asking questions to the patients in terms of how they think they're having memory problems and what's really the concern, how it's affecting them, the impact it's having psychologically, socially, the risk assessment, and if they've come with a relative, you need to be asking if it's okay for you to also speak with your relative, or if they haven't got someone else at home, would they be happy for you to print out a questionnaire and hand over so that the person at home can complete as well and bring to them, or send the link, and then the informant or relative can complete these aspects and send back to you. Dementia management, this is so blurred. I think it was the way I snipped it. It's so blurred. Let's look at this dementia, pharmacological management of non-Alzheimer's dementia. Dementia with Lewy bodies. So if you have dementia with Lewy bodies, mild or moderate over donepezil or ifostigmine. And donepezil and rivaroxaban being tolerated. If no, consider galantamine. In severe dementia with Lewy bodies, consider donepezil or rivaroxaban. If acetylcholinesterase inhibitors are not tolerated or contraindicated, consider amantine. For vascular dementia, only consider acetylcholinesterase or routine for people with vascular dementia if they have suspected comorbid Alzheimer's disease, Parkinson's disease, dementia, or dementia in anybody. Care and prescribing will be held with HPFT for 6 months before discharging back to GP. For frontotemporal dementia, which is Pick's disease, they do not offer acetylcholinesterase inhibitors or maintenance frontotemporal dementia. Parkinson's disease often acetylcholinesterase inhibitor or mild or moderate Parkinson's disease dementia. Rivastigmine is first choice due to license and evidence. Consider an acetylcholinesterase inhibitor or severe Parkinson's disease dementia. Rivastigmine is first choice. Consider memantine for people with Parkinson's disease dementia only if acetylcholinesterase inhibitors are not tolerated or contraindicated. In addition to common side effects in Alzheimer's disease, be aware that acetylcholinesterase can worsen the motor symptoms of Parkinson's disease. Look at the side effects of dementia medications here. You can see drowsiness, main side effect, drowsiness, nausea, headache, muscle stiffness, tremor. You can see that respiratory. So in terms of muscle stiffness, obviously, the acetylcholinesterase inhibitor, donepezil, galantamine, rivastigmine, you can see that muscle stiffness is not actually, because they're trying to cure the stiffness, isn't it? And hypokinesia. So they can cause headache. You can see that these medications, headache is a very common side effect. Most of them. It can also cause nausea. Peridone can be used. Quetiapine They can help with some symptoms of dementia. Like if the patient is being aggressive, if they will not sleep, you can consider some antipsychotics as well, risperidone, quetiapine can cause drowsiness. If the patient is not really sleeping at night, if the person is agitated at night, you want to prescribe things like risperidone, quetiapine, which could also help at minutes because of the sedating effects, side effects. Good to know that. Actually, look at dementia, people IBD, that's IBD with that dimension, then sleep fatigue syndrome happens to me. Still was with a headache. Just like a headache assessment. So acute headache flow chart. So pediatric clinical. This is management of headache in children. Acute headache, history of chronic or recurrent headaches. Yeah, one I'm looking for. So migraine. So for migraine, let's look at migraine treatment. This is sign guideline. This is sign. Pharmacological management of patients with migraine. So for migraine, we're looking at the acute migraine and of course migraine prophylaxis. To diagnosis, consider migraine and or in any patient presenting with episodic disabling headache. Patients with episodic disabling headache superimposed with the background of daily or near daily headache are likely to have chronic migraine. Always ask about acute medication use. If required for more than 2 days a week, consider whether they will medication overuse headache. Headache diaries can help. Symptom diary usually helps. So for acute therapy of migraine, acute treatment of migraine, avoid opiates and restrict acute medication to 2 days a week. Simple analgesics like aspirin 900 milligram or ibuprofen 400 and 600. Triptans, sumatriptan can be used first line. All oral triptans are gastrically absorbed, so may not work if the patient is vomiting. Triptans only work once headache starts. General efficacy is to work soon out of the attacks. They can be early. Yes, early or persisting vomiting agents and add an antiemetic lamictal or chlorperazine, sedative. Consider nasal zolmitriptan or subcutaneous zolmitriptan in person vomiting. There's no response, try either triptan, spiratriptan, or NSAID combination. Or something. Now, lifestyle advice is important for patients with migraine. Maintaining a regular routine is important, including the following: encourage regular meals, cause exercise, sleep, smoking cessation, cut down on alcohol, avoid specific triggers known. So that's why the importance of keeping a headache diary so you can identify specific triggers. Might be spicy food, could be certain drinks, alcohol, smoking, certain stresses. Maybe it happens when you do night shifts, for instance. You have to identify that pattern. Consider activities that encourage relaxation, like mindfulness, yoga, meditation. Preventative therapy. If we think about preventative therapy in migraine, consider if migraine is disabling and reducing quality of life. For example, if a person is having more than one, at least one migraine attack per week on average, or prolonged severe attacks. Which medications to try first depends on patient's comorbidities, other health issues, medication interactions, and patient preference. The convulsions should be avoided in women who may become pregnant. Start at a low dose and gradually increase according to efficacy and tolerability. Good response is a 50% reduction in severity and frequency of attacks. Treatment failure is a lack of response to the highest tolerated dose used for 3 months. Now, you have medications like propranolol, topiramate, amitriptyline, and desatan. Most commonly, we use propranolol as a first line for prophylaxis. That targets Target dose is 80 milligrams twice a day. You can always start with 40 milligrams twice a day, increase to 40 milligrams 3 times a day, then increase to 80 milligrams twice a day. You know, the pyramids, target dose 50 milligrams twice a day. Use if propanolol fails, women who may become pregnant with very highly effective contraception for the pyramids. Sodium valproate can also be used. Bisotifen, lacking evidence but widely used. Referral to neurology, headache may consider referral if 3 or more therapies have failed. Treatment options including flunarizine, botulinum toxin, and CGRP monoclonal antibodies can be tried. Usually, specialists, neurologists, headache specialists are always trying those. Withdrawal. If the patient responds well to prophylactic treatment, a trial of gradual medication withdrawal should be considered after 6 months to 1 year. So it means if the patient on propranolol, your aim is not to let's become a patient on propranolol forever. But the patient has been stable, with manageable symptoms, symptom free for 6 to 12 months, you might want to consider withdrawing your preventative medication to see how well the patient goes without it.